A very good evening to all present here. As we are here to discuss on women's mental health, so proceeding on discussing on the same, I would like to have my topic that is anxiety, depression, and quality of life in women with polycystic ovarian syndrome. Next slide, please. So before proceeding, let me introduce myself. My name is Anushka Sahu. I am a second year MBBS student at Bundelkhand Medical College, Sagar. Next slide. So, we all know that polycystic ovarian syndrome is one of the most common disease or the problems that the female is facing right now. And it is not just in the urban setup, it's very common in rural setup as well. It has been found that almost 7 out of 10 females are suffering from PCOS these days. And the main culprit for PCOS is basically uh, the lifestyle that we are having right now, and the food habits and the eating habits that the women are carrying right now. So why we can see that women is having other problems as well. She has other disorders as well. But why only polycystic ovarian syndrome is associated with mental health? So for that we really need to look at the symptoms and the signs that one has with PCOS. So symptoms are basically hair loss, hirsutism, pelvic pain, infertility, overweight, irregular periods, and fatigue, high testosterone levels, and acne. And if we closely observe these, we will see that these symptoms are something which is related to female's body, something that is which is affecting her social life. It is basically affecting her in a way that how she looks in the society and how she presents in the society. Next slide, please. Next slide. So, due to which we must understand that PCOS is not a disease, but it is a syndrome which involves various systems of a female body. Keeping this in mind, we must accept that the rates of depression and anxiety are very high in the females with PCOS. So, uh, proceeding on that, international as well as Indian guidelines suggest that psychological factors must be considered in all women with PCOS and they must be screened for anxiety and disorder. But the sad part is the literature researches reveal that there are only four published Indian studies on this subject. And all these four studies are also not these four studies also don't dive deep into the they also does not give the holistic idea of the women's mental health. So the India, and also we must keep in mind that the Indian perspective on quality of life in peaceways is completely unexplored, and uh, it is actually a very important factor that must be considered for a woman, because that's how the women present herself in the society, and it is affecting her in a greater manner. Next slide. So the basic aims and objectives of this research paper were to study the prevalence of anxiety and depression among the outpatients suffering from PCOS, and also to determine if any specific symptom of PCOS are associated with psychiatric morbidity, and also to compare the quality of life in patients with and without psychiatric morbidity. Next slide. So the inclusion criteria for this research paper was that the patients who were diagnosed with PCOS as per Rotterdam criteria, they must be having oligo ovulation and or it may be anovulation or hyperandrogenism or polycystic ovaries, and adult female patients should be considered for this research paper. And the patient and it should be a informed consent, and patient should be willing to help in this research paper. Next slide. And exclusion criteria include patients who have already consulted a psychiatrist and they have already been diagnosed with a mental illness by self-report or history and pursual of past medical records, or the patients who are already having any medical illness. Next slide. Next slide, please. So the various instruments that had been used throughout the study was basically the Hamilton depression rating scales or the Hamilton anxiety rating scales, World Health Organization quality of life breath scales. These were basically the different scales that had been used for analyzing the anxiety and depression in the females who are suffering from PCOS. Ma'am, next slide. So, uh, after uh, considering all these factors, a group of 70 females were being studied in a central government setup, and they were being analyzed for various symptoms like acanthosis, alopecia, hirsutism, acne, obesity, and menstrual abnormality. And it had been found that uh, it had been found that there were variable percentages of symptoms with the and in among various other females as well. So first is that acanthosis was about 12 to 9%, and alopecia was 32.9%. Hirsutism was 37.1%, acne was 55.7%, and obesity was 58.6%. And menstrual abnormality was maximum among the females, that was about 95.7%. So in this chart we can see that hirsutism, acne, and obesity, these three are the key culprits that are affecting the women the most. These three things are the basic these are the basic things which are disrupting the women's identity in a social background. That's very that is something that is affecting her a lot and causing her depression and anxiety. There were and another graph was being made in which it had been shown that there were prevalence of three symptoms altogether in 23 females, two symptoms in 15 females, and only one symptom in five females. So it's not that just only one or two symptoms are present in a few females. It had been found that not just two, it there were variable number of symptoms were being found in a variable number of females. Next slide. Ma'am, next slide, please. So, based on the studies, various tables were being made, which were basically correlating various symptoms with either anxiety, depression, and other mental health issues. And then, ma'am, next slide, please. And then complete and then summarizing these psychological factors with the quality of life of the females. And then the quality of life scores had been analyzed for various symptoms in the female, and it had been found that the females who were suffering from various anxiety or depressive disorders, they were having comparatively low levels of quality. They were basically having disrupted quality of life, and that is why they even some were having suicidal tendencies as well. Ma'am, next slide, please. So basically, concluding whatever the studies and the analysis or the statistical data that had been collected throughout the research paper, I would like to conclude whatever has been found. It was found that the prevalence of anxiety disorders was about 38.6%, and depressive disorders was about 25.7% among the females who were suffering from PCOS. And the symptoms of alopecia and not having children, that is infertility, were associated with increased likelihood of exhibiting anxiety. And the odds of associated anxiety with and without alopecia was about 3.06 is to 1. And associated anxiety with and without infertility was about 3 is to 1 almost, which is actually very high. And symptoms of acne was associated with an increased likelihood of exhibiting depression, and the odds ratio of associated depression with and without acne was 3.78 is to 1. So patients with psychiatric morbidity and significantly the patients who are having psychiatric morbidity, they have significantly lower score on three domains of quality of life, that is physical health, psychological health, and social and personal relationships as well. So patients with hirsutism had significantly lower scores of psychological domain of quality of life. Ma'am, next slide please. Ma'am, next slide please. So it was basically 75 consecutive patients were being diagnosed with PCOS at Department of Gynecology were referred for evaluation, and 70 patients consented to be enrolled in the study. Thus, a total of 70 females in the age group of 18 to 45 years were being studied, and the mean age of the sample was about 27 plus minus 7 years. Next slide, please. Ma'am, next slide. So the major limitation of this study was that it was basically a cross-sectional study that was being carried out on the employees of central government health scheme and their family members. And their characteristics may not be shared by the general population. So there was no control group for comparison with the study population. Hence, the results had to be discussed with respect to the findings of previous studies as well. Ma'am, next slide, please. So, based on the study and the research paper that I have discussed right now, I would like to extend the discussion furthermore. So, where the problem lies, first thing we have to keep in mind, the women actually goes through the various phases of life. First is the childhood, then comes across puberty, then comes fertile period, and then the menopause. As soon as she crosses puberty, she enters fertile period, where there is further two phases, menstrual phase and pregnancy phase. So, if we observe it, then we'll see that throughout this phase, we have the hormones that are coming into action. That is why there are certain changes in the female body, and these hormones are only the main culprits for various mood changes or behavioral changes in a female throughout the various phases of her life. Next slide, please, ma'am. So, keeping in mind, we should first there's something called reproductive psychiatry. If we observe this graph, we'll see that in the initial phases of life, that is till childhood, the male and the fem in male and female there is almost equal. There is almost same response. They are almost similar in their behavior. There are not much variations in their behavior. But as soon as they both enter puberty, there are various differences in their behaviors. Like female, the if we look at the graph of the female, we'll see that it is a huge. There are it is quite variable, and the depression and other anxiety disorders are quite high in females compared to males. And as soon as she exits the menopause, the depression levels also falls in female as compared to male. So we can actually conclude that hormones can have a powerful effect on the brain and the reproductive system of female, and the brain of a female is quite related to each other. And actually, these hormones play a huge role in the behavior of a female, and which is further in the behavior of a female. Ma'am, next slide, please. And we all know that in polycystic ovarian syndrome, we have disrupted hormones. There are various hormonal imbalances. They are not correct peaks of various hormones. So it is very but obvious that there will be increased levels of behavioral changes in females, and high cases of anxiety and depression. Because throughout the menstrual cycle, we have altered brain sensitivity to the normal hormone fluctuations, and brain sensitivity are actually disrupted throughout polycystic to the females who are suffering from polycystic ovarian syndrome. And next slide, please. Ma'am, next slide. Basically, if we see look at the hormone imbalances in female, we actually we'll also observe that there are high androgen levels, which are responsible for the symptoms like hirsutism, acne, and other things which are actually affecting the females. Ma'am, next slide, please. In the recent studies, it has been found that there's basically a hormone called there is basically a metabolite called allopregnolone, which is basically formed from progesterone itself. Actually, in a normal female, there is normal levels of allopregnolone. This allopregnolone is basically a neuroactive steroid hormone that is affecting the brain, which is affecting the brain, and it acts similar to alcohol and benzodiazepines, and it is basically having anti-anxiety and sedative effects in the female body. And if there is deficiency of this allopregnolone, then there will be chances that the female might be suffering from anxiety and depression. But and we know that in PCOS there is disrupted hormones. There is low levels of progesterone in the female body, and if the progesterone levels are low, then definitely there will be low pregnenolone levels in a female body, and that is basically the main culprits of
Anushka, are you there?
hello, ma'am, am I audible?
Yeah, you're audible now. You stopped being audible where you were explaining how allopregnanolone acts like a benzodiazepine.
Yes, yes, ma'am. So, ma'am, I was telling that allopregnolone is basically, yes, ma'am.
Continue,
Hello.
continue.
So I was basically telling that allopregnolone is a key metabolite that is responsible uh, for decreasing the anxiety and decreasing the anxiety levels in a female body. But in PCOS, there is disrupted hormones in a there are disrupted hormones, and there are comparatively low levels of progesterone. So low levels of allopregnolone can be seen, and thus she has higher levels of anxiety and depression. Next slide, please. So, what's the solution for PCOS? The best answer to PCOS associated anxiety and depression is simply exercise, yoga, and a healthy lifestyle. If a female does a healthy, if she has a healthy food and she does yoga and exercise every day, then her cycle will be normal, and her hormones will be normal, and other factors will also be helpful in her in getting in moving towards being normal. And we all know that yoga is something that actually helps relieving someone, and by doing yoga, women can actually cope up with the symptoms of anxiety and depression. And drugs that can be used are SSRIs or oral contraceptive pills. Basically, SSRIs are useful as they are increasing the GABA sensitivity. So they will be helpful in decreasing the anxiety and depressive levels in depression in females. And oral contraceptive pills are simply these will be helping in reducing the androgen levels in female, and it will help in further reducing the symptoms, which was something affecting the females a lot in PCOS. So that was all.
Anushka, Dr. Amrita here. Hello,
Yes, ma'am.
am I
Yes,
audible?
ma'am. Yes. Good evening, ma'am. Yes, ma'am.
Yeah. So I would just like to appreciate the efforts that you have taken. Like for a second year MBBS student, the research that you have done is really good. This is something that we expect from a PG in OBGY. So I would like to appreciate the efforts that you have taken in making this big presentation. Just one question I wanted to ask: what was the age group that you have included in your project?
Ma'am, it was about 18 to 45 years. Ma'am, reproductive age.
Okay, so it's not just the adolescent PCOS. You have taken all the age group.
Yes, ma'am. Ma'am, the mean age group was about 27 years.
Okay, okay. Because the like above beyond 35, if you compare the PCOS and depression, yes, high chance. But young patient with, so most likely this depression is because of the body shaming, like because obesity, because hirsutism, because of acne. So all
Yes,
those
ma'am.
physical appearances causes major depression in these young girls rather than any hormonal imbalance. More than the hormonal imbalance, it is the like how I am appearing, how am I looking compared to others, what causes depression in such patients. Very well thought of a topic and very nicely presented. Congratulations, Anushka.
Thank you, ma'am.
Hi, is there a question from the audience for the presenter?
Yeah, hi.
Yeah.
I do have a question. If we have a little time for that. So, Anushka, thank you at the outset. Thank you and congratulations on such a great presentation. It's very noteworthy and appreciable that at such a young age you are able to identify good studies from the literature and present it. And I especially like the part of discussion where you, I think that was not given in the paper by itself as well. The whatever you discussed in later on regarding on the allopregnanolone or all the theories behind PCOS and the issues related to it. Um,
Yes, ma'am.
yeah. So my question, I have a couple of quick questions. Firstly, I wanted to know if there was a qualitative component of the study, or was it purely based on the 3 to 4 scales which you mentioned?
Sir, it was majorly based on the scales,
Yep.
and it was the 3 to 4 scales that I had mentioned. It was majorly based on that only,
Yeah,
and
so there were
it
no
was also
qualitative component based on interviews to understand the in depth about like why the mental health issues are there, or what their feelings are. I mean, it's not mandatory, of course. I just wanted to know whether such a thing was included in the study.
sir, sir, as I have gone through the paper, I couldn't find that
Yeah, so it wasn't,
any.
you can say no, that's not a problem. Like, it's not, you have not
Yes,
done the study, so of course like whatever is there in the paper you would present it, right? I understand.
yes,
And another question I had is like, in between like in one of the slides you mentioned that like about the number of symptoms a particular person had, like which range
yes,
from one symptom and like the median was 3 symptoms, and for some it was even 5 symptoms or more, right?
yes,
uh,
sir.
yeah. So in that, I wanted to know if they have clarified about how some people had only one symptom, but were diagnosed with PCOS, because the Rotterdam criteria say that a
Yes, sir.
person
At
should
least
have
three
oligo
symptoms.
or an ovulation, or like the second one is about hirsutism or any hypoandrogenic features or biochemical tests suggestive of that. And the third criterion is about polycystic ovary morphology, right? So
Yes.
it's kind of I'm having difficulty in understand how a person would have only one symptom, reportedly, but being diagnosed with PCOS, assuming not everybody goes through sonography directly, right? So just
Yes.
wanted to know if they're clarified on their diagnostic plan in detail.
Yes, sir. Sir, there was not, sir, it was not clearly mentioned that, but ma'am, sir, I can, sir, it was there. It might be, sir, females were actually vulnerable to further getting more symptoms like that. So, if a female is having hirsutism, then
Yeah, no,
she might
that's all
develop
understood.
acne
Yeah,
further.
yeah. I mean, I would prefer answers to the point, okay? Because I just wanted to know more so that we can understand the strength of the study and because again this is not a university viva, right? So it's fine not to cover it up with other results. Okay, results are completely understood. um the
Yes.
very fact of inclusion I wanted to understand. That's all I wanted to ask. Thank you so much. It was quite a good paper where we understood some things about mental health in PCOS. And I would actually, suggest and encourage you to, if you're interested in the topic, you could take this forward and understand more, in terms of further research, like qualitative components of this, or other factors, other possibilities of studies in PCOS which you could do. Ultimately, good work. Thank you so much.
Thank you, sir. Sure, sir. I'll definitely go ahead and did will hello.
Hi, there are more questions.
Yeah, I have one.
Yeah.
So Anushka, can you tell, you have explained entirely about the reproductive psychiatry too in your research paper. So how do you think we can make women in urban and rural India more aware about this? We are doctors, we are aware, but it's more about common people. Do you think the Indian woman is much aware about all these things? And what are the steps that we can take so that we can make them more aware about this?
I think the main thing we can do is through social media only. We can actually spread awareness through it, and adding it in the curriculum itself will help a lot uh, in the textbooks, and actually popularizing it to a lot. It should not be a taboo, and it should not be something that should be that is something female should be ashamed of. It should be discussed in huge numbers, and it should be actually included in textbooks and in the curriculum of like earlier we were not aware of periods and the various female hygiene, health hygiene, but slowly we are getting through it because it has been added in the curriculum. Similarly, it should be added in the curriculum, and female should be made aware of the same. And social media, I think, plays a major role in doing that. In we can socialize it through it as well.
See, the point of social media is for urban India. Do you think people in the villages, all of them have phone, all the women are using social media? So it's not possible. It's for the urban India. So what do you think government schemes can help people in the urban, in the remote locations, know about these things? I don't think they even know about these.
Yeah, yes, yes. Government schemes will definitely help the women in. We can have the movies being made on the same.
That seems to be good.
If there are any more questions for Anushka from the audience, yeah, Soham.
Mm, So my question is not regarding the study of what has she said we can spread through what the social media about the things stuff. So, but looking at the trend whatever the thing, it will be a great challenge to just to help out with such a rural area whatever the thing. What measures being as a medical student we can do as an social work. Been asking to the women's going to the rural village what we can do in case we can do a what like skit program about is it that what measures we can take means being apart from social media, making movies, it's on a big scale. What being a medical student, what we can do? What do you think of so?
I think females in the rural setup only, we know that at least some females or they go to the doctors for treatment as well. So whenever they are approaching to the doctors, we can at that time only we can make them aware of the same, that they are vulnerable to the same, to the PCOS, or making big posters at hospitals, at the gynae departments in the rural setups.
We can do about such in the rural area, what like in MP, some we can do some for illiterate people about the things stuff we can do like the things so. And being in the government college or whatever the stuff, is it possible to any doctor to counsel about the psychiatry part, which you discuss you impact, which you discuss a lot about importance about the psychiatry one regarding the PCOS, what measures we can do at a ground level?
Right now, can't thought of it, but I'll definitely find for the same.
Yes, yes, it's a point of view of different things. Yes, it's a great idea, and it was a nice presentation by you. Thank you.
Gautam, you may ask your question.
Like Anushka, I wanted to ask. Okay, I understand that there's not much awareness in India because since we still are a developing country and from a long time and maybe will be. What about the status of these reproductive psychiatry in developed countries like US, UK, or Australia? Like, are you aware about it? How much aware are they about this particular topic, or even they don't have much awareness about this too?
In the developed countries, earlier they were not aware, but recently, when I was going through these researches, I actually found that now the people in the developed country are really aware about their psychiatric health and associated with the PCOS. I have found that in the developed countries, their main cause of anxiety and depression was postpartum. The postpartum depression and anxiety was more prevalent than the anxiety and depression which was associated with PCOS.
Like, do you have any figures or any statistics about it? How many percent in
Sorry,
what?
right now I can't give the exact figures.
Okay, no issues. But like, it was a great presentation, Anushka. Congrats.
Thank you.
Thank you so much. If there aren't any questions, maybe Sangram can go next. Sangram, are you still here? Presenter 2, Yash Patel won't be able to present because he's facing a lot of internet issues. So, Sangram, you might have to go next. Please let us know if you're in the meeting.
Hello, am I audible?
Yes, you are. You're ready?
Uh, yes, I am. Actually, I am traveling, so I didn't get much time to read about the research paper that I'm presenting, but I'll try my best.
That's
So,
on.
I'll
You
try
can.
to share the
Mhm.
screen.
Okay.
So, my screen is available.
Yeah.
It's visible.
Yeah, it's visible. You can start.
Hello there. I haven't made any kind of PPT presentation or things like that. So, hello, my name is Sangram. I'm a third year medical student from Government Medical College and Hospital, Chandrapur, Maharashtra. So today, I would like to thank Clinically Evolved to give us this opportunity to present these papers. Okay, so my topic is intimate partner violence and sexual coercion among pregnant women in India and its relationship with the depression and post-traumatic stress disorder. So this was a study done on 203 pregnant women in the state of Karnataka, and in further time we are gonna discuss about it. So, as we know that this topic is more vulnerable, the intimate partner violence, the developed countries like Australia and United Kingdoms also have 20% prevalence of IPV among pregnant women. So it's uh, the according to the study done in 2002. Talking about this study, which is done in India, the participants were taken, or the inclusion criteria was based like the pregnant women should be from the age range of 18 to 49, which is reproductive age. The second, they could speak English or Kannada fluently. The third inclusion criteria was they must submit their informed consent before participating into the study, and they should not be uh, they should not have any history of severe mental illness like bipolar disorder, schizophrenia. So the procedure is a simple procedure that they have done for this study. They trained some research assistants and provided them with the basic questionnaire in English and Kannada both. And then they were asked these questions to the participant pregnant women to assess the IPV, that is intimate partner violence, and its relationship with the depression and the PTSD. So the measures that they have taken are firstly the socio-demographic characteristics of women. Second is about their current pregnancy, that is parity, prenatal care, injuries, any hospital admissions. And the third is spouse's socio-demographic characteristics, whether he is alcoholic, he is employed or not, his education, age, and all the details. The study was based on or the questionnaire that they have made, and they have told their trained research assistants. They were based upon some scales, and mainly this questionnaire based on the index of spouse abuse uh, given by Hudson and McIntosh in 1981. So based on its, they made a questionnaire. They haven't mentioned their questionnaire in this study. I don't know why. So there are few other scales that they have used, like sexual experiences scale, scale of assessment of somatic symptoms, Bake's depression inventory, post-traumatic symptom checklist, satisfaction with life scale. Uh, yeah, so these are the scales that they have used for preparation of questionnaire of this observational study uh, that they have done. Talking about the analysis, they have uh, determine the prevalence and the severity and the nature of intimate partner violence and its relationship with the socio-demographic details that we have taken and its mental health indicators. So they have studied life satisfaction, depression, somatic symptoms, and PTSD scores. Talking about the results or the what they have concluded. Firstly, socio-demographic characteristics of the participant. They have mean age of 23 years among the 203 pregnant women that they have studied on. Majority of women, like half of the women, were between the age range of 21 to 25. 33% of the women were less than 20 years of age, and 20% of the women were more than 25 years of age. Hello, am I audible?
Yeah, you're audible.
Yeah. So, this is the age distribution among the study. they have discussed few parameters here, like the religious basis. The more than half, like 55% were Hindu, 39% women's were Muslims, and 6% were Christian. And their parity also, like 43% were primary paras, 20% had more than one child during the period of assisted, and 3/4, that is 76%, had either primary or high school education. 13% have no formal schooling, and 10% had attended college. So most of the women, like 77%, were from urban origin, and remaining were from rural origin. So yeah, this is the distribution. The prevalence of intimate partner violence and the sexual coercion gives us data of in the past year of their pregnancy. 28 of 203, 28 of 203 women about reported physical violence. 30 women reported psychological violence, and all of those who reported physical violence also reported psychological violence. Of the 30 women who reported either physical or psychological violence in the past year, 8 of those, 15 of women who reported violence, 8 of those who reported violence in all the 3 trimesters of the pregnancy. Sexual coercion involving force, like 4 to 10 out of SES. Sorry for the further discussion that I haven't read the part just below here. So yeah, I would like to discontinue here. I'm sorry.
No problem. Thank you so much, Sangram, for your presentation. Ma'am, if you'd like to share your insights about it.
Sangram, am I audible?
Yes, ma'am.
So Sangram, if you have been given such a big platform to display, you should have taken at least the pain to make the PPT. Like rather than
Yes,
just
ma'am.
showing us the paper, it is difficult for us to read through such a small handwriting. It would have been better
Yes,
if you
ma'am.
could have made a PPT. But let me tell you, the topic that you have selected is very, very good. It would have made a very good presentation if you would have put in some efforts. And when you have been
Yes,
given a
ma'am.
platform like this, you should have put in little efforts from your side. The
I've
choice of your topic is
s-
extremely good, rare topic to talk about. Uh,
yes, ma'am.
very less
I
discussed topic among gynecologists, though it's prevalent,
I'm
we all know. So I would have
I'm so
been
sorry
happier if
for
I would
the
have been able to see the conclusion part.
yes, ma'am.
Yeah. Okay.
Ma'am.
See, like in
I'm
our government setup, we see so many women coming in pregnancy with trauma. Like we get admitted, like saying that history of abuse by husband or history of like we have seen many cases of violence even in pregnancy. So we all know that it's very much rampant, but a never
yes, ma'am.
discussed topic. So yes, especially in pregnancy when the woman is in the most need of like support from her partner, and at that time if she
Yes, ma'am.
overcome if she like experiences all these things, the depressive symptoms, the post traumatic stress disorder symptoms obviously are much more.
Yes, ma'am.
Anyways,
Uh,
you should have put in
Actually,
more
I'm
efforts. Yeah,
yes, ma'am.
that's it.
I'm sorry. Actually, I'm traveling to the Pune for my work, and it's Like I didn't need,
But this
I haven't
was
got a time
informed to
to
you
read even
prior.
also.
This must have been informed to you prior. It's not something like you are presenting on a short notice or something. I have been informed
Yes.
a week before, so I'm sure the presenters must be aware of it. Anyways, a good topic, just needed little bit of um presentation. It should have been made into a presentation.
Yes, ma'am. I'm sorry, ma'am.
Thank you so much, ma'am. Are there any questions for Sangram from the audience?
Someone has asked a question in the chat box.
I think it's for our knowledge. I think what Ananya is asking. I think that question is directed to Amrita ma'am. If you could help us gain more insights on the topic by answering Ananya's question. She has asked whether we routinely or regularly ask patients about mental or physical abuse, even if it is not outrightly indicated based on examination or based on history. Is that an essential question? And I would also like to know about it personally. So, Amrita ma'am, if you could please help us understand more about this.
Yeah. So, like in urban setting, yes, this issue is usually addressed. Like whenever antenatal patient comes to us, we do ask about their coital history, about history of violence. But the problem comes in rural areas. In rural area, this issue is not at all discussed, and that's where the problem lies. In urban cities, we are well aware how to like Kaltana, a woman like mental health is usually assessed in one of her antenatal visit at least we will be able to find out her mental status. But the problem is in the rural in India where this problem is not solved because usually such patients are registered with either a DAI or a primary healthcare center where the health providers are usually not well trained in picking up those points which are important.
That is so insightful, ma'am. Thank you so much for that. Um, in addition to that, I had I had a question myself. Just to introduce myself, I'm Porus. I am an intern at CMS Medical College.
Yeah.
Uh, so, uh, is somebody else speaking?
Vanshika, if you can just unmute your.
Uh, Sorry, ma'am, can you repeat?
No. Yeah, as I was speaking, ma'am, yeah, so I have wanted to ask, like, could you please help us, with some insights on areas to identify where we could work on a research level as well as on social or volunteering or advocacy level, where we can address these issues of intimate partner violence and work something as an organization or on an individual level. This I'm asking also as the I'm the executive director of SIMSOG,
Okay.
so we do quite some activities and initiatives in the area of ObGyn. So this may be something which we would be interested in taking forward and trying to do something so as to uh,
So, like for
bring
us,
positive
yeah,
outcomes.
yeah. So I was just going through your like I was just I went through your so finally you're an intern at KM Hospital if I'm not wrong.
Yes, ma'am. Yes,
Yeah.
ma'am.
So for us, I'm happy that you all are so interested in this research work and you all are taking this platform in a very good way. Like the research that I'm seeing, I usually don't see such paperwork even in my in my residence. I'm a PG teacher also. So I would like to really congratulate you guys for doing this excellent research work. And as far as your question is concerned, so what we can do is like till now, even we have not included this in our antenatal criteria. But after reading this, definitely the 3 scales that they have mentioned, we can include one of the scale in our antenatal card, so that at least we will ask, like, now what is usually happening is people come with history of violence, and then we ask them questions and then we interrogate. But what we want to do is prospectively, like not retrospectively, we want to prospectively ask this patient, all the patients who come to us for antenatal visit. So yes, we can take one of the skills that he has described in his study, and we can include it in our antenatal card, so that every patient who comes, we can ask them about their mental health and about the intimacy or any problem related to it.
That sounds like a wonderful suggestion, ma'am. Like, totally, I understand.
Yeah.
Especially, like, rather than to take secondary or tertiary level of prevention, we could go on a
Yes.
more primary level
Yes.
of, or even primordial for that matter, level of prevention, like what we
Yeah.
learn in community medicine. So
We
that's
can
like,
just include it,
yeah,
like just we have an ANC card where we
yeah,
tick mark CVS, we tick mark
yeah,
RS, we tick mark everything. We can just have a column for mental health, and
exactly, yeah,
this 4 5 questions that we need to ask, and just a brief, like whether she is
yeah,
mentally sound, whether she
yeah,
has a history of trauma, whether violence history. We can just
yeah,
tick mark and
yeah.
include
Yes,
it in
yes,
our
true, true.
antenatal card.
Yeah, I mean, like when we like, that is so insightful, and kind of like a light bulb moment for me. Like, honestly, in any of the cases, like, or like, learning we do in systemic examination, we do CVSRS,
Yes, yes,
CNS, and GI, or per abdomen. But
yes.
essentially, mental health is also such a important factor,
Important
and
topic,
all
but
of us are like
yeah.
MBBS graduates, right? Even if we do post graduation, like we are expected to know the other systems. Even psychiatry or mental is something we
Yes,
should
yes,
know for the at least basic level. It should, like,
yes, yes.
of course, for people who are screen positive, we can refer them to psychiatry or psychology for further interventions or so. But identifying at the root level of it sounds like a very good suggestion, and thank you
Yeah.
so much, ma'am. Like,
And that's
really
what
love
you
that.
said, Dr. Matre, that some amount of psychological counseling, some amount of psychiatry, we all as gynecologists should know, because we see so many cases of post-traumatic stress disorder. And to differentiate it from an organic lesion, because if a patient has a thrombus in the brain or something, the symptoms will be similar. So how do you differentiate whether this is an organic cause or a psychological cause? So basic level of psychiatric training needs to be done by all post MBBS residents.
Absolutely, ma'am. Thank you so much for these insights.
Dr. Deepika has a question.
Yes, thank you. I just wanted to ask that do we have any legalities or obligations on our part as a medical physician when we encounter such cases, when we establish such cases in our OPD, IPD setup?
Yeah, so when a patient, like whether pregnant or non-pregnant, any patient who comes to us with history of trauma, so we usually do an EPR. So EPR is nothing but informing the police. So the police comes and take the official statement, and the statement that they give to the police, that will decide the future course of action, like whether she wants to put in a complaint against her husband, whether. So from our side, it's always necessary that whenever you see that there's something, like many of the time the patient hides from us, so it's always better to do an EPR and let the police decide, so at least we are safe on paper that we had informed the police. Because many times we have seen that we have missed it, like a patient who comes to us with abortion, we do everything and we send it, and after 3 months you get a letter from the police saying that this patient has history of trauma, was abortion because of trauma. So how are we supposed to judge it? Like, so it's always better, if you think that there's a history of trauma, please inform the police, do an APR.
Thank you, ma'am.
If there aren't any more questions, Vanshika, I think you can go ahead now.
Okay. So this was a really wonderful session. And thank you so much, Dr. Amrita. You were amazing. You gave us such helpful insights to the audience. And a great thank you to the presenters also for presenting such wonderful cases. We learned a lot from this.